So these are not reasons for contemplating a termination of pregnancy. We are depending on will judge unless it's a combination of these anomalies. A baby having a large VSD, ASD, and PDA combinations causing a lot of overload to the heart, causing congestive cardiac failure in utero, which is a rare situation. Babies having an isolated anomalies of these just shunts, VSD, ASD, PDA doesn't matter much. We can manage them well postnatally. And I just want to emphasize that even for the major abnormalities like a transmission of great vessels and coarctation of aorta, if they are isolated anomalies, if they are not part of a complex cardiac anomaly, if they are pure TGAs or they are pure coarctation of aorta, we do have excellent support from the cardiothoracic team. And in the last decade, and especially over the past few years, we are giving more than 90 to 95% outcome going for an early surgical correction of these anomaly, complete corrections, switches, arterial switches happening soon after birth. Babies getting these babies don't have once they come through of the surgery and do well, they don't have even any significant morbidity later. So cardiac is something which we can, though it's better to avoid. If it happens, we do have definitely a hope and modalities available. The screen is gone blank again. Do you hear me?
Yes, sir. It is fine. It's fine, sir.
Yeah. This is just like to touch upon thing. This was discussed repeatedly. So it's very interesting to note that. So the risk of having a congenital malformation exponentially increases depending upon the control of hyperglycemia. If you look at the HbA1c value, which reflects the glycemic control, so the rough number seems to be anybody who has an HbA1c level of more than 7. So we need to evaluate them in detailed screening anomaly scan has to be done. But if it keeps on increasing like up to 9, you see the numbers jump. So less than 7 is fine. The moment it goes from 7 to 9, you have a 14% incidence of malformations, and then it keeps on progressively increasing, reaching up to 25%, 1 in 4 babies when the levels cross 11 grams percentage of HbA1c. Okay. So so fine. This is about the first trimester, trying to avoid these congenital malformations, and maybe trying to have a word involving the neonatologist to discuss if you happen to have an abnormality, which abnormalities are compatible with life, where facilities are available for correction, which ones are not compatible. So that I think we have discussed a bit. So moving to the second part, the second trimester and the third trimester, okay, when the hyperglycemia happening in that period. So as I said already, it is a combination of hyperglycemia in the baby and hyperinsulinemia in the baby. So automatically this leads to hyperinsulinemia, leads to a big baby, macrosomia. It's not just the baby is looking big, it leads to many organs are big, especially even the heart. The accumulation happening, having problems like an hypertrophic obstructive cardiomyopathy organomegaly happens. So macrosomia is hardly a problem in the in utero period. It's an indicator of the control, what is happening. So we all know that the macrosomia becomes problematic only at the point of delivery. So our obstetric colleagues and friends, they have a very tough time, especially if the mode of delivery is vaginal. So we do come across, so they are forced to undertake C-section for many of these babies. But despite their best of the efforts, we do see a lot of birth injuries in these babies. The commonest ones we do see are fracture clavicle, fracture humerus, cephalematomas, subdural bleeds, brachial plexus injuries, and all. So most of these injuries are actually they're not very worrisome. Say, for example, fracture clavicle, we don't do anything for that. It heals well. Even a fracture humerus. So unless we are just only worried about the blood loss, if there is no significant blood loss causing hypotension in the baby, the bones heal very fastly in babies. So it's just a matter of time for the bones to heal. Cephalematomas lead to a bit of jaundice. The hospital stay increases. They will require phototherapy and all, but it doesn't bother the baby much. One injury which worries us is this brachial plexus injury. Brachial plexus injury is because it is a big spectrum. So there are so it's very, very difficult to assess soon after birth whether we are dealing with a simple form of injury, which like a neuropraxia, or we are dealing with something like an extreme form of injury, which is a neuronormosis or an axonormosis. So the outcome is going to depend on the amount of injury that has happened to the brachial plexus. So the simplest even though even MRIs cannot provide much information. So the simple thing is that babies who do recover within a period of say 2 to 3 months, if they who develop a complete recovery in the first month or two, they do fantastically. But if we do happen to have babies who show persistent abnormalities or who don't recover well in the first 2 to 3 months, those are babies who may have some sequelae or might require invasive surgery later. That is something which we need to avoid as much as possible and be careful. Not a very other injuries we are quite comfortable. Okay. So just once the deliveries happened and provided there are no birth injuries, the major problem what we see in infants born to diabetic mothers is babies having a respiratory distress soon after birth. So always in these diabetic babies, even if they have reached a term gestation, even if they're more than 37 weeks of gestation, a diabetic baby showing a respiratory distress can't be just ignored like some other baby saying just give some time, give a 1 hour or 2 hour, this fellow will settle down, it may be a simple TTM, there is no need to worry. So you just see the chart in the left. So insulin inhibits the effect of cortisol. We know the cortisol is very much essential for production of surfactant in the lungs, and it has got a lot to do with the maturation of the lung. So the graph compares the baby's lung maturity in non-diabetic and diabetic across the gestational age. In x-axis, you see the gestational age. So these babies who are born to diabetic mothers, even though they are bigger babies, if they are of a higher order gestation, it is likely that even at 38 and 39 weeks, some of these babies can have surfactant deficiency and respiratory distress syndrome. So that's why we always insist on whenever a baby has got even a mild distress, so that respiratory distress syndrome presents in a different way in these small babies. It will be a very mild form to start with soon after birth. It will be just a mild tachypnea. And if you just forget to, or if you fail to recognize this problem, you send the baby across with the mother, or you just don't shift it to a proper unit, this might quickly worsen and babies might develop cyanosis and hypoxic respiratory failure soon. So it's an X-ray is mandatory to rule out surfactant deficiency, see a whiteout lung. This is a term baby actually. This X-ray is of a term baby, which is showing a total whiteout lung. Many of them might require, but they do respond well to surfactant therapy once we recognize this condition. Even if we say if it is not RDS or a surfactant deficiency, the incidence of the so-called transient tachypnea of newborn, which is attributed to the delayed expulsion of fluid from the alveoli, it's quite high in these babies. That means it might take somewhere between 24 to 48 hours for these babies to settle down, some of these babies, because the fluid stays there, and we would always like to put these babies on a respiratory support, like CPAP, pressure support will be required. So if a baby has got respiratory distress, it's better to be in a unit which can provide respiratory support in form of oxygen and non-invasive respiratory support. Okay, and other reason, any baby with respiratory distress, we should never forget the possibility of this baby having a compromised cardiac function. Don't just think it's only TTN or RDS. This is a very, very common problem, hypertrophic obstructive cardiomyopathy. Actually, this is, I didn't put this in as a part of a congenital malformation because this is nothing to worry. This is just a transient problem. I should say this is something like an organomegaly. Some accumulation of, so this heart has become big, but it has happened in disproportionate way where the septum is more hypertrophied compared to the rest of the ventricle. But what happens is because the septum is very much big, this bulging of this extra septum causes an obstruction to the outflow. So these babies, even though they're having a good contractile heart, they may have problems in they may not have a good LV output. So, it's always preferable in babies who are showing respiratory distress soon after birth, in diabetic babies or diabetic mothers, to have an echo done to rule out major anomalies like a TGA or a coarctation, and to rule out this important problem, hypertrophic obstructive cardiomyopathy. But hypertrophic obstructive cardiomyopathy, we are not worried about this problem because this is easily manageable. We tend to use beta blockers if there is an obstruction documented with the help of our cardiologists. Mostly we use oral propranolol. There are some babies, if the obstruction is very severe, these are not the babies where the use of inotropes and the use are contraindicated in this condition. Because if you try to increase the pumping, it is going to cause more obstruction. So inotropes are contraindicated. Go for beta blockers, propranolol. Oral propranolol for a short time, say 2 or 3 days, works well in most of the babies. Rarely we have used intravenous propranolol also, but this resolves over a period of time. And for it to totally settle down, for the hypertrophy to disappear, it takes some months. But within a few days, the baby will become all right. Okay, so any of these, so a baby on a respiratory support, recurring respiratory support, consider all these 3 possibilities in an infant of diabetic mother. Okay, the second major problem, often missed problem, and is having these hypoglycemia. So obviously the insulin levels are high, and we know that these are bigger babies. The reasons are multiple. Even these babies, first of all, their demands is quite high because of this macrosomia. So their surface area is quite high, the tissue load is quite high. But these babies are in general very lethargic babies. So they don't suck well at the breast. Many mothers, it is a documented fact that the lactation doesn't happen well in a mother who has got problems in her sugar control, especially who has an insulin. So it's problems are multiple levels. Mother doesn't lactate well, baby doesn't suck well at the breast, the demand of the baby is quite high, and there are quite a few some babies where their insulin levels are quite high, which is going to bring down the level of sugar. So hypoglycemia is, we won't be able, it's most of the time it remains silent, and suddenly a baby may throw a seizure, and then so we have lots and lots of babies picked up from the postnatal ward coming to us in the where sugar monitoring. If we fail to monitor the sugar levels, and it will be picked up only when the baby throws a seizure, and that can lead to long-lasting implications of the brain. A symptomatic hypoglycemia can cause a lot of damage to the brain with the long-lasting implications. So we insist a lot on the only way out is an early and aggressive sugar monitoring starting soon after birth. And the duration, we are coming down, the protocols keep changing about the sugar monitoring, but at least for the first 48 hours. Frequent monitoring in day 1, starting soon after birth. I'll prefer to do a sugar, like say sugar at 2 hours, 6 hours, 12 and 24 on day 1. Depending on these sugar, these give a fairly good idea what is happening to the baby. The second day, you can just do only 2 values which are 12 hours apart. If all the values are okay up to 48 hours, by 48 hours you assess the lactation. If lactation is happening well, hardly there is a necessity, hardly these babies develop any problems later, you can leave. But if there is a fluctuation, some values are okay and there are some values going which is less than 50, especially if your value is close to 45 and 40, any value coming 50, if it is even fluctuating, you have to be careful. You have to extend the monitoring for another, say, another 24 hours or 48 hours. Okay, you have to keep a watch on the feeding. Not only they do have a problem in whenever you are happen to have a baby who is lethargic, jittery, and baby who are throwing convulsions, we need to always think about the possibility of hypocalcemia. So these babies, their prothermone surge doesn't happen, parathermone surge doesn't happen. So they are likely to develop hypocalcemia. Most of it is asymptomatic, but some babies may throw a symptomatic one. So, and always do magnesium levels in these babies. So the reason behind hypocalcemia could be a hypomagnesemia. If you keep giving only calcium to these babies, if their magnesium levels are low, the calcium will not get corrected. We have to see the magnesium and correct the magnesium also to have a consistently normal calcium levels in these babies. So just to touch upon some things which we face, these are not common problems. Feed intolerances are quite common. They may not feed well, but this is some form of this lazy left colon syndrome. They will have a tummy full. You see a lot of a small bowel obstruction like picture happening there. But a barium gives you a picture where the small bowel, the left colon especially, looks very small. But again, this is not a structural abnormality. Just please we can very well reassure the parents. This is just with time, this settles down. So all these things, even the barium enema itself is a considered contrast enema, acts as a treatment. So these babies settle down. We need to recognize this condition, but we don't need to be worried. It's very well manageable, self-limiting condition. With time, just with the barium enema, this is easily manageable. And polycythemia, we have to look for it. Babies will be plethoric. It can lead to jitteriness, it can aggravate hypoglycemia. It will lead to more jaundice and need for phototherapy. So anybody who has got a hematocrit of more than 65, keep a watch for jaundice, keep a watch on the sugars in these babies. Rarely this polycythemia can lead to hyperviscosity and can lead to problems like necrotizing enterocolitis and renal vein thrombosis. The proportion is much less, but we have to keep that in the back of our minds. So some basic workup, at least in a babies, even if they're asymptomatic. I will try just sugar monitoring is very mandatory. Babies who are lethargic, please do magnesium and calcium along with glucose. You do a bilirubin at 48 hours to 78 hours in all babies or anybody who's looking icteric, and the blood counts just to mainly look for polycythemia. I'll say these 4 investigations are mandatory in any baby who is born to a mother, especially if your control is not good. Depending upon if in babies having respiratory distress, we may go for an X-ray, okay, echo, and other investigations. Okay, so this question is often asked. Okay, these are all short term and looking good. What about what happens in the long run? So does it influence the neurodevelopment of this baby in any way? Do these babies develop any problems in the long run? So I should admit that the information available is a bit controversial, and even though there are some papers which have shown a little bit of, we don't have any major developmental problems, but when looking at problems like their levels of school functioning, their scores, IQ scores, some papers say that kids born to mothers with uncontrolled diabetes tend to perform a little bit lower compared to other ones. But there are lots and lots of confounders right now. With the available evidence is not very clear. But one thing is very clear: we know that these kids do have an increased risk of developing diabetes later when they become adults. So that has to be kept in mind. So that's what I just wanted to present today. The major problems what happen in the first trimester and the second and third. At the time of delivery, mainly asphyxia and birth injuries. A neonatologist or a pediatrician has to be there to attend these deliveries. The parents has to be counseled about these babies who might require some care in the NICU. And fortunately, many problems are manageable. Many birth injury, most of the birth injuries, all the forms of most of the respiratory distress, and most of the feed intolerance. But we need to be very active in monitoring for the sugar levels. Don't allow these babies to develop a seizure, hypoglycemia, especially in the postnatal ward, or to babies who are, these 2 babies you need to be cautious. Having some distress soon after birth and sugar monitoring. I will try to emphasize on these 2 factors because this is the commonest missed thing which happens, which we see often happening in the postnatal ward. I think thanks for the opportunity. I'll stop here and I'll be available for further discussion.
Thank you, Dr. Mangala Bharati, for that very exhaustive talk. We never conduct even a vaginal delivery or a cesarean without having the neonatologist with us. So we know how important you are to us. Thank you.
Thank you, ma'am.
Now, may I request Professor SESHIAH sir to present his interesting cases for the day. The slides are up, sir.
Yeah, thank you very much, Manju. Now, I want to discuss about few facts which all of us should know. Many conferences have seen a few of our colleagues recommend, of course, Dr. BALAJI told correctly. Now, what is happening in other places, SPG more than 90 milligrams to diagnose GDM. This many times, last GDM symposium also it was told 92 should be the diagnostic criteria. Now, let us see how far this is tenable in our population. I'll go with the case study here. Blood test done on 10th December 2018. If FPG was 85, if we had thought to, we would have missed that. We thought no, we are normal. Now, fortunately, the physician who did this test he also did again post-meal test. It was 186. So the physician must have got alerted. He referred again to another place to know that more test was done. DTT. Here again, fasting was 80. Imagine if we had done only fasting, both the time you would have missed. If we had followed FPG 92 milligrams for diagnosis, you would have missed this case. So the message from this study is fasting plasma glucose fails to diagnose GDM in Asian Indians. This is published. Everything I'm giving the references, international journals. So what is the reason? Inadequacy of fasting plasma glucose to diagnose GDM. This is the data. In relation to fasting plasma glucose 92 milligrams, there is a considerable variability between countries noted in the hyperglycemia and adverse pregnancy outcome study group, that is from DIPISI, with fasting plasma glucose diagnosing only 22% of GDM in women in Bangkok, Hong Kong, compared with the 71% in some US centers. This is obvious. The South Asian people fasting blood sugar can never diagnose GDM. Whereas in Caucasians, it is possible. But we did Hong Kong, Bangkok. Again, in India, a low diagnostic rate of FBG has also been reported in Asian Indians with a fasting plasma glucose of 592 milligrams, diagnosed only 0% GDM. That means we have followed the criteria recommended by the International Asset Development Study Group. All the Asian people would have been diagnosed some GDM.
No.
So relying on FBG of 92 milligrams for diagnosis, you would have missed 78% of GDM in non-Caucasian women. Caucasian women different. So the non-Caucasians, Europeans are entirely different. The reason here is why it is like that. Why? Increased insulin resistance during pregnancy in Asian women results further in GDM. That is the reason. And again, FBG is not an appropriate option to diagnose GDM in Asian Indian women as insulin resistance is higher compared to Caucasians. All GDM, FBG values, in all GDM, FBG value do not affect the postpartum blood glucose, which is the hallmark of GDM. Again, fasting may be impractical and questionable in settings where the detection of hyperglycemia and pregnancy based on fasting value is low. So these are the reasons why in non-Caucasian FBG won't pick up the GDM. And not only in India, Southeast Asian had the lowest BMI, most of us very thin, lowest fasting, but yet highest 2-hour blood glucose value or certified glucose tolerance test. So these are the reasons why fasting below 92 will not pick up GDM in our population. So it is not my opinion also, but also opinion of the WHO is if RCT shows benefit of treating GDM women identified primarily by post-load values. And again, there is no high quality evidence that women and their fetus benefit from treatment if only the fasting value is abnormal. So elevated postpartum glucose may be more predictive with the potential for fetal morbidity compared with fasting or prepartum values. Therefore, fasting glucose values alone do not predict the need for pharmacological therapy. All these points I told just now indicates we are depend more on the postpartum blood glucose. And again, Anand Shankar also told that BALAJI has told about this point. Now, recent publication was in this publication they found recommending FBG more than 92 milligrams for diagnosed GDM is not prudent. In conclusion, we suggest that the use of International Diabetes Study Group fasting glucose threshold of 5.1 millimoles, that is 92 milligrams, for identification of GDM is not justified. So I'll leave here with this. Now we'll get next study, case study. Here, this lady, Premigravida, she had a GDT, 96 milligram fasting, 188 to 91, A1C salt 5.7. Now that means she is from our recently did diabetes must be 96 fasting, most about 2 or 181. So 10th week. So fasting 96, 2 hour PG was 181. So as again, as I told many of our speakers, Ashok Das and Anand Shankar, we won't straight away go for treatment meal plan. So for 2 weeks we maintained meal plan, and we found on 12th week it comes to 92. That shows meal plan is ideal. That's as I told by Dr. Shilpa Joshi also. When meal plan fails, then what when follow? When 24th week, and what happened was fasting was 85, still normal, whereas 2 hours went to 144. So we started them on insulin, mixed start 50-50, because we always prefer ratio 50-50. Then post breakfast high, it will start only with 6 units. And then what 30th week, just 86, 148, oh, we increased to 8 units because I want to bring it down 120. Then by 35th week, it came to 84, 118 with 8 units of insulin, and then delivered 36th week by electric section, newborn birth weight as 2.75 grams. So the message from this slide is meal plan is given for 2 weeks. Every human must be given if it is going to be in the margin area. Whereas insulin initiation, it is a message for our audience here, insulin initiation not to exceed 0.1 unit per kg of body weight. Suppose GDM is not a very severe diabetes, like type 1 or type diabetes. In GDM, if you want to start insulin, the advised dose is 0.1 unit per gram. Suppose the weight lady weighs 60 kilo, you can only 6 units, not more than that. Another study I'm sharing with you here, a 30-year-old lady, third gravida, and then this obstetric history, nothing abnormal. She had undergone a blood test around 28 weeks of gestation. Fasting was 102, 2 hours, 140 milligrams. The over-attending doctor was there. These values were ignored. They didn't take care of this. Then at 35 weeks, when she went for routine ultrasonograph, it revealed fetal macrosomia. Then she was advised to do GDT. When GDT was done, at 60 weeks, fasting was 131, 1 hour 279, 242. She was then referred to us, our center. We did again, investigation was done. Our center, it was fasting 112, postpartum 172, A1 with clear case of missed GDM. She was then immediately started her on insulin and reviewed her again. When I reviewed her, after 1 week itself, we are able to bring her blood sugar to normal by giving no mix, 8 units in the morning and 6 units in the night. Outcome was real section was done at 38 weeks. So next pediatrician was telling newborn baby was 4.5 per kg. Fortunately, in spite of that, neonatology are able to save the child. Nothing happened. The living baby is there. So these are 3 important cases to share with you. Then repeat screening, again, Dr. BALAJI told a significant number of women whose glucose tolerance was 2 pg, less than 140 milligram, even less. So was normal in the first visit, do develop glucose tolerance in subsequent visits. Therefore, we have found out to us that 28% of women were detected to have GDM repeat screening subsequent visits. So we have done this also. A1C more 6.5 first time must indicates pre-GDM. But A1C is not possible in all the patients in the country, small areas, small villages, taluk, it's not possible. So not only we feel that way, and again this is this from the WHO, they says there are very little data on the use of A1C to diagnose diabetes pregnancy. That's very clear message. No necessary to do A1C. We do it, it's okay, but not necessary. Consequently, the 2013 WHO guideline does not include A1C as a means of diagnosing diabetes in pregnant women and for monitoring. So, if anybody talks on A1C, let you listen to them, but I don't think it's possible because each lab will have different value. No two lab agree to same level. So let us go only with the blood sugar. So here one small message I would share with you. If you do normal glucose tolerance, IGT in type 2 diabetes. Why this 140 milligram? 140 milligram because when blood sugar crosses 140, that means 50% of beta cells functions lost, not lost, function is lost. So that is why we said 140 is a very important number in the medicine. IGT 140, GDM 140, like the number of places where 140 is very important. Yes, the reason is physiologically 50% of the beta cell function is lost. So this has to be recognized. And then that is why I said the non-pregnant adult 2 pg more than 140 milligram is considered abnormal. Then why can't it be considered abnormal? That is why we said DIPSI criteria 140 milligram is diagnostic of GDM. So diagnosis of GDM 2 pg more than 140 milligram and treatment is worthwhile. The decreased macrosomia rate, fewer emergency cesarean section, serious parental morbidity may also improve the woman's health related quality of life. So if you take this carefully, probably you can avoid a number of problems for the perinatal period. So, friends and gentlemen, gestational week ideal for screening as suggested by Dr. Balaji. Here, screening for glucose tolerance in the first trimester and care could avoid some diabetes and related complications such as hydramnios, fetal anomalies, and preterm birth in women with this diabetes. So, thought is accepted, but I think somebody asked this question: when, if possible, how to make the woman understand the moment that she knows she is becoming pregnant, almost it will be 10th week. So that somebody asked question, 8th week people can get, child can get anomalies. So the only way is a message, as somebody told you, then what do you call that? Celebrities must talk on the TV sometime. They must tell the moment woman misses a period, she must go for the blood test. It's so simple. The glucometer test can be done, or you can ask lab people to come and do the blood test. So your thought is generally we tell it as soon as possible that the first time itself, but I would suggest if possible, should be done the day she misses the period. As again, I State Health Society, it's a very, our government has done this. Optimal guidelines for diagnosing GDM in the community. Direct test, there's no question of one test, again do one more test. Direct diagnostic test with glucose and measuring 2 or post glucose. And then this can be done the first trimester, weeks of pregnancy. It's routinely done, this is routine. But I think you will go a step further and do earlier possible. Second test, 24 8 weeks, and finally 30 to 31 week. That is the guidelines given by the government and as well as Minister of Health, Government of India. So friends, my final message, most complicated problem in this universe has a simple solution by Albert Einstein. So my message here will be one test, 70 gram glucose, irrespective of last minute timing. That's a very useful test, this one. And then one value, diagnosed GDM, 2 LPG, more than 140 milligrams. And another message, one simple message will be here, one target, the 2 postprandial plasma glucose, 110 mg. If this is followed, probably we can have a better fetal outcome and can avoid lots of complications, complications. So please follow this simple message which I am giving you now. Thank you very much for your patient hearing. Thank you very much. Now,
dear friends, yeah, I think I will just have 3 questions, one each for each speaker. I think the first question for the Anand Sankar is a very simple question, but looks very complicated to me. What is the role of minimal tolerated dose insulin in improving the fetal survival? You know what he's meaning, Anand, is that even if insulin is not too much indicated, you can give 1 or 2 units to increase fetal survival. Is it indicated, not indicated?
Absolutely, absolutely, sir. As just heard Professor SESHIAH, sir, that we can start even 0.1 unit per kg body weight. Insulin is must, as Dr. Mangla Bharti sir was telling, that we have to control the sugar is more important for the better fetal outcome. It is not the dose of the insulin. It is the insulinization is more important than the dose of the insulin.
Even I think your message is very clear.
Even one unit is important to control the for better fetal outcome. We must give it.
Fine. Fine. I think the message is loud and clear. The insulin is the number 1, number 2, number 3 drug for GDM and pregnancy and diabetes. Nothing can surpass it. And it is very important to use the array of insulin. Those have been approved for use in GDM. There is one more question, that where will you use this very fast-acting aspart versus aspart alone?
Sir, the fast-acting aspart is better used in those set of patients in which the postprandial is not getting controlled with aspart or regular insulin, and in which the fasting is under very much control. In those set of patients, only the fast-acting aspart has a role to play. Otherwise, no, this pre-mix analog is very much convenient to use, and we are getting very good result with that.
I think you said that. You said about the analogs, its flexibility, and its very, very great use. Madam Anjalakshi, I had got 2 questions which have been asked for you.
Yes, sir.
Somebody,
Yes, sir.
somebody,
I am audible, sir.
somebody wanted to know. Yeah, yes, very much audible. Oh, she wanted to know what are the types of scan that you normally ask the GDM mothers to come for, and the COVID time, is there any modification of the scan visits?
Scan visits, they can, first thing, no, they should have a scan in the first trimester between 11 to 13 weeks. There is no alteration because of the COVID. That will help you to find out the early anomalies as well as for Down syndrome screening. That is 11 to 13 weeks. Then they should have a scan at 20 weeks for the anomaly as well as for the fetal echo. That scan should be combined with the fetal echo. These two is regarding the growth scan. If the blood sugar is under control, they can postpone or they can actually avoid this growth scan unless there is a doubt regarding the macrosomia.
Thank you, ma'am.
Okay, these
very.
I want to ask here. That is, I hear a number of publications saying that pregnant women are not so much vulnerable for COVID. Is it true?
Yeah, it is true, sir. That's also Anjalakshi said. That's also literature says that the ladies, pregnant mothers, are not susceptible, and even if they get, the disease is not serious. Unlike diabetes, hypertension, asthma, it is not serious.
Yeah.
That's what they move. And we have also put it in the government guideline released yesterday. Madam, there is one more last question for you. In general, do GDM mothers deliver early?
No, sir.
Okay, that's what they wanted to know, and that's about.
See, there is a chance for the preterm delivery. There is a chance for preterm delivery. The incidence is increased actually in cases where there is a poor control of blood sugar. If you take the pregnancy with a good control of blood sugar, they go through the pregnancy normally as a non-GDM mother.
So,
okay. And yes, sir.
So recently I came with another case. This is Mangala Bharati is here. That is primary. After 5 years of marriage, she conceived, and then what happened, don't know. Then she went for a delivery some other hospital here. Then she was referred to government hospital here. Then the child had respiratory distress syndrome. What could be the cause, Mangala Bharati? No, she's not diabetic.
She was not a diabetic.
Yes, Mangala Bharati.
So, and was it a term gestation, sir?
Was the lady diabetic, sir?
No. Her father is a diabetic, but she's not diabetic. Gestational at the full term. She went for delivery. Then the peripheral hospital, they said, no, we can't manage. You go to Chennai. She came here. By the time they had to do cesarean section, the cesarean was then they found child has got a respiratory distress syndrome. Of course, this was a problem to save the child.
Okay. Thank you, sir. Even though maybe the case sheet or the discharge summary would have mentioned it as respiratory distress syndrome, as the name itself says, this term is very loosely used for many babies who are having respiratory distress soon after birth. It's just like a syndrome. Even for some babies who are having problems in their adaptation just soon after birth, it doesn't RDS, respiratory distress syndrome, doesn't always translate to surfactant deficiency. So the many term babies, even without diabetes and all, can have some form of problems in their adaptation, and it may last. The duration may last even up to say 48 to 78 hours, requiring some amount of respiratory support. But that doesn't mean they are having surfactant deficiency. It may be just simply a problem in adaptation from the intrauterine environment to the extrauterine environment.
Okay, might be. Yeah.
That baby was 39 weeks, Mangala Bharati, 39 weeks baby.
Right, ma'am. Most likely should be a form of what we call as the malignant form of transient tachypnea. But just because if it's only because of the delayed expulsion of the fluid, that's what we call as transient tachypnea of newborn. most of these, around 95% of these transient tachypnea settle down the first 24 hours. But there are some 5% cases where it takes 48 to 78 hours for them to settle down. But it is only fluid in the lungs, nothing else. Just give some pressure support and good oxygen. They don't require surfactant. They settle down over a period of time.
With the child, we lost
questions to Dr. Mangala Bharati. The question is very, very exciting question to you. For the embryopathy, one factor is the hyperglycemia.
Yes.
But it is also observed in spite of a normoglycemic control, not too often but rarely, there can also be effects of embryopathy. So what other factors do contribute to embryopathy beyond hyperglycemia, which are modifiable, which are not modifiable?
Okay, I think rather than an interesting question, I think it's a very difficult question to answer because to my mind, actually the exact pathophysiology of the alterations happening in the embryo, because it happens very soon. So we were discussing it happens even before pregnancy even is diagnosed. So apart from the glycosylation which is in effect, and maybe other experts can help me. To my mind, or as far as my reading goes, I'm not sure actually whether these mothers who did not have a pre-diabetes before pregnancy are at a higher risk of having it normally if their sugar levels are normal. I have not read the paper saying that they're at a higher risk of having abnormalities despite having totally normal sugars.
When I saw the question, I think probably is referring to beyond diabetes, some genetic
There
factors.
could be other reasons also, no?
Some genetic factors, something.
Yes, there are other reasons for.
Yeah, there is no diabetes specific factors. Diabetes specific factors are not there. Thank you. The other question to you is very significant question, Dr. Mangala Bharati, is you said two complications which are very important. One, you said hypoglycemia. How often it is missed? Hypoglycemia in the newborn.
Yes, sir. I'll say it is the rates of missing a hypoglycemia keeps coming down over a period of time, but I should admit it is still happening because it's a very complex issue. Because even with in today's world where people read a lot over the internet and do a lot of their own reading before delivery, parents don't like the baby getting pricked. So especially say pricking the baby repeatedly at every 6 hour interval. The moment you step in, they look at you like you have come to do something which is unnecessary for the baby. The baby is looking fine. The baby is feeding well. So definitely we need to talk to the parents. They have to be prepared before delivery. They should not just come as a surprise. Like if they are not prepared, they should be told before delivery. Say
Yes, I mean, quite you have to make the parents understand it's a must.
Yes.
It is for the baby's benefit, and they must go for it. The questioner wants to know. Yeah, the questioner wants to know: does your hospital and the advanced center in neonatology does it have a protocol of monitoring neonatal hypoglycemia, and what is the protocol?
Thanks. I'll be happy to share our protocol. So our routine protocol is to do a sugar on the first 24 hours of life. The first value, blood sugar value, is done at 2 hours of life. The second value is done at 6 hours of life. And then the third value is at 12 hours, and the fourth value is 24 hours. We are doing 4 sugars in day 1. But if these values are showing any fluctuation, like we are having values which are going below 50 or values which are close to 45, we would do a frequent monitoring like 8th hourly monitoring on day 2. But if all these 4 values are more than 50 on day 1, I would just like to do only 2 more values on the second day, that's 12 hours apart. They're also more than 50, and if you're happy with clinical assessment, the lactation is happening well, we don't do any monitoring from the third day onwards, provided all these values are normal. But as I said already,
I think it's a very useful information. I think you should put it in your presentation. That will make it complete. I think very useful information. Yes. There is another question to both you and to Dr. Anjalakshi. Is there are some pregnant mothers, GDM pregnancy diabetes mothers, who go through repeated stillbirth, be referring to a patient who had 9 repeated stillbirth in search of a live baby. So she just wants to know, she's a gynecologist, I'm sure. She just wants to know what are the factors, what can be done. Is there any biomarker that can prevent this lady becoming again and again pregnant? Correctable, non-correctable? I think I'll ask Angela first, then come back to you. Repeated stillbirth, madam.
Repeated, there are other factors also. See, for example, if they are cases of systemic lupus erythematosus, SLE problems, so they have hypertension, early onset hypertension, that also can result in IUD. Okay, so whether she is a diabetic, throughout the diabetic, she is a non-diabetic, sir, having stillbirth. Hello.
Yeah, I think she has not mentioned, but possibly there was no hypertension, madam. Possibly, I cannot ask now. Maybe it will take time. So, but she has not mentioned about the lupus, nor mentioned about the APLA, nor mentioned about not APLA positive. Has not mentioned about.
Sir, my experience about this problem of repeated fetal wastage. When I was in the department, we used to visit the Institute of Obstetrics and Gynecology. Then we had a doctor, no more now, Moni Bansal. We had a similar problem of fetal wastage. Then there was a reference in a book, I forgot the book's name now. These are the prophylactic insulin. Because
I am given.
You are at the particular time maybe normal, other time maybe you're not, unless you do the yes. Pardon?
Yeah, so I think sir, that was my first question to Dr. Who this about diabetes Anand Sankar. I was asking about this minimal tolerated dose insulin for fetal salvage. My first question.
See, there are 2 ways. Prophylactic insulin is a very small dose, depending on 4 or 6 units per day. Only you must be attributed to Excel. It has produced very good results. It has published also. So this tolerated maximum tolerated dose is different. That means that is that we don't follow in India because some people follow in abroad. They give that amount of insulin which the woman can tolerate. They go by sweating.
Develop hypoglycemia.
Which is dangerous. By India, you don't know all the time you are sweating. You don't know when you sweat. Low sweat gas.
Correct. So it should be called prophylactic minimal dosage.
Yes, is there. It is. I have our library. The book is there. So
okay. Very good answer.
Sir, I had one patient.
I've got last.
Sir, I had one patient, Dr. A.K. Das. I had one patient who was 11th gravida, had lost 10 babies. 10 babies, first 3 abortions, followed by IUDs. 7 IUDs she had. As sir said, I have given her a prophylactic dose of insulin, and she happened to be a hypertensive. She had IUD, the rise of hypertension and IUD. Abruption, one pregnancy she had abruption. So with the multiple therapy, we have given her a low molecular heparin plus prophylactic insulin. With that, now I was able to take the pregnancy to 36 weeks. But that time the BP rose to 180, 120, then I have to deliver her. But I sent the patient with a live baby. So that patient has a combination of treatment.
Thank you, madam.
Prophylactic insulin plus low molecular heparin, everything.
Thank you, madam. Thank you, madam. Very interesting. Last question to Mangala Bharati and then to Professor SESHIAH. The last question, the last question, Mangala Bharati, to you is a very interesting question. It says about that you said regarding the 2 common things that everybody must remember. One you said about the hypoglycemia, and the other one you said about other one. You said Mangala Bharati. One is hypoglycemia, other one.
Respiratory distress syndrome.
RDS. So the questioner is possibly an intern. She's telling that in the partography, when they do partography in the labor room, is there any indications? Is there any signals? Is there any ways of identifying beyond the usual signs of fetal distress? Anything else because as Madam says, Cynthia Madam said, the pediatricians there throughout. But is there any biomarker? Is there any novel features to diagnose this fetal distress which can lead to RDS?
Yes. The question is quite interesting because that means trying to predict the lung maturity in the in utero period in these born diabetic mothers. Facilities are available, but all these facilities are invasive. So you need a sample of the amniotic fluid to do those tests. We can estimate factors like phosphatidylglycerol, phosphatidylиnositol in the amniotic fluid, and then in diabetics, actually, in general, we do phosphatidylglycerol, but phosphatidylglycerol is more sensitive in diabetic situation. But all these are invasive tests where you need to take a sample of the amniotic fluid, and it is not, the results are also, it takes time to, we have to send them to specialized labs, and you have to wait for days to get these reports. So it is actually, these tests over a period of time have become obsolete. They are all just only areas of research of interest. So what I'm trying to say is that it is enough. The pediatrician has to anticipate that this baby can have a lung immaturity, and it's a easy clinical decision at the time of birth. If a baby doesn't have breathing difficulty at the time of birth, you don't bother it. It won't come back again. If the first for 30 minutes, if the baby is breathing well, this baby is not going to get a problem. So if a baby has got, what I'm saying, many babies do have problems. What I want to emphasize is that many babies, say around 10 to 15% of the babies, even without any morbidities, will have some breathing difficulty. That means that's what we call as transition. They will have a mild tachypnea, which settles down. So in general, we do, if the gestation is all right, you just wait, keep them for 30 minutes in the, and then it will automatically disappear. But this strategy, just leaving them and thinking that the pediatrician leaving the baby and just going home thinking this baby will become all right, is dangerous in a diabetic situation. That is the baby which has to be reviewed, because these babies may look okay at the time of birth, but this distress may progress and may land up in problem. If you miss it, then it is difficult. That's what I want to emphasize.
Brilliant answer. Last is the greatest appreciation for Professor SESHIAH's words of wisdom. Sir, we have taken with very seriousness your note that the fasting sugar can never ever give a diagnosis of GDM. We have also taken it with a lot of interest the values of the criteria, the concept that you gave today of the mixed GDM. The mixed GDM is a concept which must be flashed across the country. I'm going to speak about it in the other meetings, because mixed GDM should become a phenomenon not to miss. And the way to do it is to do a 2-hour post glucose, and also the second case where you said 100 to 140. I think when it is 140, it was necessary to repeat the 2-hour PPGS for that particular patient, and I think it was not done. Then ultimately you did it, you found it out, but there was a 4.5 kg child. And Balaji, you have given a beautiful concept which are again emphasized, is regarding the repeat screening, and it is inexpensive. It is available with the home held house, the handheld glucometers. So there is no reason why repeat screening should not be done. You know, today I think Anjalakshmi Madam mentioned about the intermittent CGMS, and I'll be talking about the TIR, time in range, in the meeting on the 1st of August. I must tell you that it has become mandatory today that multiple glucose estimation is important. You need not do CGMS. You can get similar information from the multiple home-based glucose monitoring. Am I correct, sir? So the glucose monitoring is paramount diabetes management. You cannot look at the person and say he's diabetic. So Rakesh, Anand, and Balaji, thank you very much. Mangal Bharati, thank you very much. You are across the specialty. We belong to the same tribe of so-called quote-unquote diabetes. But Mangal Bharati, thank you very much. My sincere regards to Anjalakshmi Madam and to Cynthia Madam. And I'll make it over to Professor SESHIAH for the last word. But I must tell you, sir, the interest, I can see the number of people still logged in, and the interest for this very important disease and to handle it is so great that the time that you gave us today was very well spent. Sir, your pulse of wisdom will ever remain in our mind. And with these words, I make it over to you and Cynthia Madam for closing it, and maybe last